Hi, everyone, and welcome to tonight's webinar, Mental Health Medicines for Children and Adolescents. Before we start, we just have a few domestics. So tonight's webinar will be recorded, and so bear that in mind if you want your cameras on or off or etc. Please keep your microphones muted. If you're having any problems with connectivity, if you just turn off your video, and sometimes if you have difficulty with sound, just make sure that your speaker or sound is not muted on your computer or phone, or you might be able to try logging in and out again. We have the chat function and you can put comments or questions there. You may use anonymized information from the webinar tonight, and Grace is going to put in a post-webinar survey at the beginning now, but at any point during it and before the end, we'd really appreciate it if you would fill it in and tell us what your feedback and what kind of things you liked about the webinar and would like to see more of. And then questions throughout, just pop them in and we'll put them to Caroline at the end. So delighted to have Caroline Hynes here, Advanced Specialist Pharmacist in the Adolescents Unit in St John of God Hospital. And she's also affiliated to both RCSI and University College Dublin. I think we're in for a really, really interesting evening on a beautiful sunny evening, but a fantastic presentation. So I'm going to hand over to Caroline now, and really looking forward to hearing all the information. Thanks, Caroline.
Thanks a million, Emily. So I'll just share my
yeah, I'll let you know when you we can see it properly and everything. Yeah,
perfect.
And just as Caroline is presenting, if you do have questions, pop them in the chat box and we'll put them to her at the end. Yeah, that's perfect, Caroline. Can see it perfectly.
Great. Amazing. So I think as Emily said, I'm an advanced specialist pharmacist. I work in Genesa, which is the Adolescents Unit in St John of God Hospital. And I've been there since 2021. So it's not that long, but I've worked in adult mental health services for maybe 15 years before that. So in both St John of God Hospital and also in the UK. The kind of learning outcomes for this evening are there's quite a lot of information, and some, it is very much kind of a brief, almost like bird's eye view of child and adolescent mental health. So I'm going to give a bit of a background on prescribing for children and adolescents in Ireland, and then we'll go through, the different medicines that are used or that you might see, whether it's in the community or hospital setting, for depression, anxiety, bipolar disorder, psychosis, eating disorders, and ADHD. And again, it's quite an extensive topic, Cam. So it is very much just kind of a bird's eye view. We'll also look at side effects and physical health monitoring and some kind of side effect support that could be provided from a pharmacy perspective. And then I'll be able to signpost you to resources where you can seek further information and support, whether it's for your own interest, but also then if you need to direct people, children or parents or adolescents that might be looking for more information on mental health medicines. So mental health conditions are among the leading cause of illness and disability in adolescents and young adults, and their prevalence and diagnosis have been increasing over recent years. So presently 1 in 7 people aged 10 to 19 experience mental health difficulties. The three of the top 10 causes of disability adjusted life years for adolescents, so those aged kind of 10 to 24, are actually mental health related. So it's self-harm, depression, and anxiety. And suicide was the 4th leading cause of death in 15 to 25-year-olds. So I think it's really important to understand, I guess, how important and how prevalent mental health conditions are amongst young people. And I guess it really highlights the need for obviously early intervention and support, but also for kind of awareness and for education for healthcare professionals, pharmacists, being really important in youth mental health and youth mental health medicines. So alongside this kind of increase in kind of diagnosis and experience of mental health conditions amongst children and young people, there has also been a global increase in the prescription for children and young people of mental health medicines. So, that includes antidepressants, antipsychotic stimulants, sleep medicines, anxiolytics, and mood stabilizers. Early intervention, at the first onset of a mental health condition improves loads of outcomes. And, the benefits are maximal when young people are kind of targeted around the time of onset of a mental health condition. So when you see this kind of increase in prescription of mental health medicines, it's not necessarily a bad thing. It might be a case that actually, young people are being kind of illnesses and diagnoses are being identified earlier, and then they're being treated at an appropriate time. I think it's really important, given this topic, to contextualize the kind of press that's been around regarding CAMHS in Ireland. And certainly, my own mother, who obviously knows that I work in this area, would ring me anytime she hears a news story about something about CAMHS. And I think, obviously it's not all good news, but it's really important to highlight that the people that are working in the services are all, working incredibly hard, doing an unbelievable job. And, when you kind of see it on the ground and you see all the different disciplines that are involved, it is a really challenging time. And I think, the groups are really kind of working to improve the services with the means that they have. It essentially came about really on foot of the Maskey report, which was a review of a regional CAMHS centre in Ireland. It was South Kerry, and it was carried out between July 2016 and April 21. And it was completed by Dr. Sean Maskey, who is a retired consultant psychiatrist who worked in CAMHS in the UK. So the Maskey report essentially determined that, it was published in January 22, but it determined that the care received by 240 patients, so 240 children and adolescents, failed to meet required standards. And there was clear evidence of significant harm to 46 children in the files that were reviewed. So the kind of key areas that the report highlighted were that there was an unreliable diagnosis of the children and young people, there was inappropriate prescribing of medicines, and that there was poor monitoring of adverse effects. And when you looked at the 46 children that experienced significant harm, this included galactorrhea, which is the production of breast milk, which is a side effect of antipsychotic medicines, hyperprolactinemia, and considerable weight gain, again, a side effect of antipsychotic medicines and some antidepressants, sedation during the day, and elevated blood pressure. So on foot of the Maskey report, the HSE actually commissioned a post-Maskey audit, which examined kind of the other mental health services providing care to CAMHS, children and adolescents nationally. And the main takeaways from this were that 70% of the children attending CAMHS were prescribed one medicine, 23% were prescribed two medicines, and then kind of just under 5% were prescribed three medicines, and a very small number were prescribed four. But 95% of the medicines prescriptions were in fact overseen by a consultant psychiatrist. And one of the recommendations, which I really liked, and I think it's kind of a really important part of this talk this evening, was that pharmacists should be integrated into all CAMHS teams. So, presently there aren't that many CAMHS pharmacists in Ireland. There's, maybe 2-3 people, and as far as I'm aware. But I think that's why the community pharmacists or other hospital pharmacists play a really important part of the care of children and adolescents with mental health conditions and looking after mental health medicines. So this publication, Rebecca Parkin published it just this year, I think, earlier. Yeah, it was just this year, and it's really interesting, where she looked at looking at the prevalence of prescribing in all mental health medicines. So it was from 2017 to 2021. And, I've mentioned we've obviously seen a global increase in the prescribing of mental health medicines to children and young people. So this study wanted to look at prescribing in the Irish context. So the rates were actually found to be, whilst they were higher, there is an increase in prescribing. Antidepressants were the most commonly prescribed, then antipsychotics, then stimulants or non-stimulants for ADHD, and then sedatives and hypnotics. But actually the rates in Ireland were found to be lower than international comparators. So another study, this is Laura Bond, who's a consultant psychiatrist and works out of Crumlin. She looked at the kind of impact of this post-MASCI audit on prescribing, on the prescribers in Ireland. And, it obviously the audit had really positive impacts around prescribing practices. So the study revealed a welcome improvement in prescribing practices. So medical record keeping had improved, over 60% reported improved medical record keeping, over 50% reported improved consent documentation, over 40% reported medicines information provision had improved, and over 60% had reported the physical health monitoring had gotten better following the post-MASCI audit by the HSE. But over 40% of psychiatrists actually reported a reluctance to prescribe medicine, even when it was clinically indicated. And about half of those who participated were more likely to avoid off-label use. And this just means that there's a kind of a reduction in appropriate prescribing for young people, and it kind of deprives children and young people of effective treatments. So the study kind of highlighted that there was a need for national clinical prescribing guidelines, and also increased public awareness of the evidence base, to ensure that, clinicians feel confident that when prescribing medicines, that there's a solid evidence base on which to base their decision, as opposed to, trying to align with the license of the medicine, because there really aren't that many medicines that are licensed for children and young people. And those that are licensed mightn't necessarily be the best options. So, prescribing for a child obviously is different for an adult. We know, as I've mentioned, many medicines aren't licensed for use in children and adolescents, and that limits choice. And obviously this was highlighted in Laura's study, that there was a reluctance to prescribe medicines off-label. It's really important, I guess, to understand that just because a medicine isn't licensed in Ireland, it doesn't mean that it isn't safe and effective for children and adolescents. So there's some medicines obviously that are licensed in other countries, and certainly we would often look to the US to establish whether a medicine has been licensed there or is being used there, because it means then the medicine has been assessed for safety and assessed for efficacy. So it's safe to use and it works, because otherwise it wouldn't have a license. And also, we also would look at whether this medicine has been used and has been assessed in randomized controlled trials, or is recommended in any other international guidelines. So a child is obviously still developing, so behavioral differences need to be seen in that context. Children are less likely to spontaneously report changes in how they're feeling. They obviously need to wait for an adult to notice and seek help. So it might be a parent, or it might be a teacher, or like a sports coach. And also sometimes children don't have the verbal skills to kind of put their problems into words. So there's some principles of prescribing that we kind of align to when you're looking at children and adolescents. So the first one is to target symptoms and not diagnosis. So a child or adolescent mightn't actually have a clear diagnosis, especially if this is their first experience of a mental health condition or a mental health difficulty. I've obviously mentioned licensing. There aren't that many medicines that are licensed for use in children. So the kind of technical aspects of prescribing come into play, when you're prescribing a medicine that maybe is only available in a tablet. So sertraline is a really good example. It's actually licensed for children from age 6 for obsessive compulsive disorder. So you can only get a tablet, and it's only available in 50 milligrams. Obviously it can be split, but you're only getting, 25 milligrams. You can't really go lower than that. Start low, go slow. Children and young people are actually much more susceptible to side effects of medicines. So starting at a really low dose and a really gradual dose titration is often adopted, and this is just to ensure tolerance. Multiple medicines are often required. So young people, as I mentioned, they might have a clear diagnosis if it's their first experience of mental health difficulty, and they might have symptoms that maybe one medicine won't manage or support. So they might need a few medicines. Allowing time for an adequate trial is just to ensure, obviously it can take longer to reach therapeutic dose because you're starting really low, you're going slow. And also children maybe take a little bit longer to respond to medicine than adults. So it is kind of a longer process. So you do need to kind of allow time for an adequate trial. Where possible, change one medicine at a time. So generally, with children and adolescents, if they are taking more than one medicine, because they're quite sensitive, it is best practice to just adjust one medicine, whether it's the dose or switching to a different medicine. And then you're able to attribute any changes, whether they're positive or negative, to that particular medicine. The outcome needs to be monitored or measured in more than one setting. So it's not just whether things improve at home. It also needs to be whether things improving in school, things improving in after school activities, things improving with friends or family. And finally then is patient and family education about medicine is essential. And I will be signposting you to some resources at the end. So 50% of all lifetime mental health conditions begin by age 14 and 75% by age 24. And then for ADHD, which is a neurodevelopmental or neurobehavioral condition, the symptoms are usually there before age 12. I mean, kind of from age 3, probably symptoms could be identified. So it is really a critical time, this period of childhood and adolescence where mental health conditions present. And as I mentioned, early intervention and early detection and early support mean that young person or that child will have the best outcomes. This slide is a bit of a jumble, but it's really just to give you an idea of the kind of comorbidities that are related to mental health conditions. So they often co-occur with each other, as well as ADHD. So someone might be experiencing more than one set of symptoms, or one experience different difficulties, and it might be that they have co-occurring mental health conditions, or they might have a neurobehavioral or neurodevelopmental condition that co-occurs with a mental health condition. And while medicines are one support, and obviously a helpful support for mental health conditions and also for ADHD, they're often reserved for moderate to severe symptoms, and they often result in the best outcomes when they're used alongside psychological or other interventions. So I'm obviously discussing medicines in this webinar this evening, but I guess it's really important to know they're not generally the first line. It's kind of moderate to severe illness and moderate to severe impairment, and they're usually recommended alongside other interventions, mostly psychological. So kind of mild to moderate symptoms or mild to moderate conditions, usually the first line is a psychological intervention. But I don't discuss what psychological interventions are, because we don't have time, unfortunately. So I'll start with depression, which is among the more common mental health conditions in children and adolescents. We saw it in one of the earlier slides. Depression, anxiety, and self-harm were kind of in that three of the top 10. Nearly 3% of youth worldwide are reported to have a depressive disorder, and nearly 30% of those with a major depressive disorder reported some form of suicidality in the past year, and more than 10% reported a suicide attempt. So it is a really, really, really important condition to identify and to support a young person with. The rates of depression in younger children are kind of lower, so it's more of an adolescent condition. So the medicines in depression then, fluoxetine is essentially the only medicine that's licensed for depression in Ireland. It's licensed from age 8, and it's indicated and recommended for moderate to severe depression, but only in combination with a concurrent psychological therapy. So it's fluoxetine, and fluoxetine is quite a good one, because fluoxetine, as we know, has a really long half-life. So for a person who isn't really used to taking medicine, fluoxetine, because it stays in their system for such a long period of time, if they were to forget a dose, it doesn't necessarily result in those kind of discontinuation or adjustment effects. So it is kind of, in that regard, it is a good medicine, given that long half-life. If fluoxetine is ineffective, or if it's poorly tolerated, sertraline or citalopram should be considered, and this is what's recommended in NICE. But actually, when you look at the data, escitalopram has a license for depression in children and young and adolescents. So we would often see either citalopram, but potentially more often you might see escitalopram. There's limited evidence for other treatments beyond these medicines. So if someone has been tried on an SSRI and they're switched to another SSRI and it's considered ineffective or it's not working as well, it's really important given that there isn't a huge amount of evidence for the next steps, to look back on these interventions and ensure that they were kind of, did the person experience a side effect and stop the treatment too early? Or, is there any way that one of the medicines could have been, the dose could have been increased, or they could have been used in a better way or optimized? The side effects of SSRIs are generally the same. So kind of nausea and vomiting, feeling you're getting sick, diarrhea, headache, feeling more anxious, loss of appetite, trouble sleeping, and then the kind of sexual dysfunction or less interest in intimate relationships. The other medicines that you might see, and again, this isn't based on evidence as such, are mirtazapine or venlafaxine. So if a child or a young person truly does have depression, they've tried all the evidence-based treatments, there isn't actually any evidence to guide the other options. If the young person is kind of close to 18, it may be reasonable to try antidepressants shown to work in studies of adults, so those aged 18 to 64. So these are the mirtazapine or the venlafaxine. And certainly these are medicines that we would see in practice. And, given kind of these are the next line for adults, it does seem reasonable for them to be used in children and adolescents, certainly older, those that are maybe approaching 18. It's important, I guess, to note that caution with venlafaxine is advised just because of that possible increased risk of suicidal ideation. The side effects of mirtazapine are slightly different to the SSRI. So it's has antihistaminergic effects, so it leads to drowsiness and increased appetite, and also dizziness, dry mouth, and headache. It doesn't have sexual dysfunction, so sometimes it might be something that is preferred for maybe an older teenage boy or someone who's experiencing that as a side effect. Venlafaxine then side effects are the same as SSRIs. But you might also get, as the dose increases, some of the noradrenergic effects. So like the increased or the dry mouth, dizziness, and increased sweating can occur. What's interesting about venlafaxine actually is that at doses of up to 150 milligrams, it's essentially an SSRI. Between 150 and 225, it's an NRI. So it does have that noradrenergic effect. And then above that, it has some dopaminergic effects. So it is a medicine that can be helpful for someone who maybe was on an SSRI, because you can do a direct switch to venlafaxine at a low dose and then gradually increase it. Side effect, pharmacists are obviously medicine specialists, and when it comes to, supporting a young person who's experienced a side effect of an SSRI, it is kind of handy to have these kind of tidbits or bits of information that you can provide. And I guess feeling or getting sick, nausea, and vomiting is one of the more common side effects of SSRI. So it happens to 1 in 5 young people. If a parent or a young person comes into you and is saying, listen, I'm getting the side effects, I feel like I can't take the medicine anymore, there's some advice that you can provide and support them with. So, taking the medicine with a small amount of food, like crackers or toast, can be helpful. Eating smaller meals more often during the day can also help. And then drinking plenty of cool water can be helpful, or sucking on sugar-free hard sweets. The side effect is linked to dose. So, if you have kind of made these recommendations and the young person or the parent comes in and reports that actually the side effect is still there, and, you can link in with the team or the consultant or the GP, and certainly, dropping the dose, prescribing a lower dose and increasing it more gradually, or sometimes even splitting the dose between morning and lunchtime can be helpful. The duration of treatment in depression, so to date, only a few studies have evaluated kind of antidepressant discontinuation in use with depression or depressive disorders. The recommendation is kind of a 6 to 12 months after remission. So once the young person or the child has recovered from the symptoms, 6 to 12 months after that. Ideal kind of candidates for antidepressant discontinuation are those who have remitted substantially or substantially improved, provided, I guess, that they've experienced a sustained relief over a period of time and that their functional impairment is no longer present. And ideally, again, discontinuation during a relatively stress-free period. So if someone has been taking an antidepressant for a year, for example, and they're just about to do their junior certificate, that's not a good time to discontinue their medicine. It might be better to wait till the exams are over and then kind of have a period over the summer where the medicine is stopped. There's no specific monitoring recommendations associated with antidepressants, the SSRIs in particular. Citalopram and escitalopram are contraindicated with other medicines known to prolonged QTC intervals. So it's really only if someone is taking another medicine that has a drug-drug interaction. But outside of that, there isn't any specific kind of baseline monitoring that is indicated for someone who's taking an SSRI. Anxiety then. So anxiety disorders are among the most common psychiatric disorders in children and adolescents. So nearly 7% of youth worldwide have an anxiety disorder. And the median age of onset is 11 years. So it is slightly younger. You know, it's kind of between that kind of childhood and adolescence. So it's a little bit younger than depression. The medicines in anxiety then, again, you know, psychological interventions are first line. I've mentioned that, particularly CBT. But SSRIs are indicated for moderate to severe illness. Sertraline in particular is actually licensed for obsessive compulsive disorder from age 6 to 17. And with OCD, the kind of higher doses might be more effective than the ones that you might see for depression, for example. The duration of treatment for anxiety, again, like continue for approximately 12 months after remission. Anxiety can be a chronic mental health condition. You know, it isn't something that is kind of, you know, you might get one experience and then it goes away, never comes back. The optimal duration for continued symptom remission is unclear, but you know, if someone was to decide that they wanted to stop a medicine, it's really important to monitor for the reemergence of symptoms for several months after it's stopped. And also, you know, there are people with severe chronic anxiety that may require longer term treatment. And again, discontinuation during a relatively stress-free period is recommended. So psychosis. So again, you know, it is one of those kind of more severe mental health difficulties, mental health conditions, and it does present in adolescence. So about 12% of psychotic disorders and 8% of schizophrenia cases have onset in childhood. Schizophrenia spectrum disorders often first present during kind of adolescence, so it's not really that common in childhood. But so first episode obviously is more rare. But again, you know, this is quite a significant mental health difficulty, and if it is, you know, if it does present in this period of adolescence, it is really important that the person has access to the same level of care as an adult would. So our kind of international guidelines essentially recommend a second generation antipsychotic. So the choice is usually determined by the values and preferences of the individual with regard to kind of side effects. And actually at the moment, myself and some colleagues are working on a guideline on the management of or the first medicine, so the first antipsychotic, the choice of first antipsychotic for females with first episode psychosis. And actually, you know, when you say kind of a second generation antipsychotic, you know, take your pick out of all of these medicines, consider all the side effects. It is kind of a choice overload. So our guideline has kind of looked at really what are the priorities for a young person, and in particular a young female, when it comes to side effects. And we've identified that cardiometabolic side effects, which are kind of weight gain, dyslipidemia, diabetes, and also the hyperprolactinemia, so that's elevated prolactin that can result in amenorrhea, or as I mentioned, gastria, the production of breast milk, or sexual dysfunction, and longer term, you know, potentially osteoporosis and an increased risk of breast cancer. So they're really important kind of side effects that, you know, maybe we should be identifying medicines that are on the lower end of the risk scale for those kind of more harmful side effects, and recommending medicines that are more appropriate. So aripiprazole is one, and certainly we're seeing it being used a lot more. And it has the lowest risk of hyperprolactinemia and the lowest risk of cardiometabolic side effects. And it's also licensed. So it's licensed from age 13 in Ireland. Now it's for mania, but it's still technically licensed. Other medicines then, asenapine has a low risk of hyperprolactinemia and a medium risk of cardiometabolic side effects. And this is a medicine that we're recommending in our female guideline. So asenapine, it's not licensed in Ireland under 18, but it is licensed in the US. So we know that it has, it's safe and it's also effective in those under 18. And then the other one is ziprasidone. So ziprasidone has it's like the kind of switch of asenapine. It's a kind of medium risk of hyperprolactinemia and a low risk of the cardiometabolic side effects, so the weight gain. And what's really interesting, and I find kind of really interesting, is ziprasidone is licensed in Ireland for under 18s for mania, but it is licensed. But we don't really see it that often. But hopefully it is one, given the kind of more maybe tolerable side effects that and maybe not as harmful, as weight gain and elevated prolactin. This is a medicine that we might see more of as maybe once our guideline is published. These are typically the medicines that we are seeing. Risperidone, it's got a high risk of hyperprolactinemia and a medium risk of cardiometabolic side effects. So actually we, published a guideline in December on the use of metformin to prevent antipsychotic induced weight gain. And for a young person, our recommendation was actually anyone who's taking risperidone, who's a child or an adolescent should also be prescribed metformin. So it's from age 10. But, it's a high risk of hyperprolactinemia, which can actually impact bone health in the longer term. So, it is being used. It's licensed in Ireland from age 6, but not for psychosis. It's licensed for conduct disorder. So I don't know. It's kind of a tricky one. Olanzapine, again, a medium risk of hyperprolactinemia, but a high risk of cardiometabolic side effects. And for young people, dyslipidemia and weight gain are quite significant. I'll just fly through the side effects. So aripiprazole, it's a partial D2 agonist, so it has slightly different profiles to the others. Kind of restlessness is usually the main side effect of aripiprazole. Olanzapine then, the kind of weight gain is probably the main one, and then risperidone with some side effects there. Side effect support then for someone taking antipsychotics. So increased appetite or weight gain. 1 in 7 young people gain 7% or more body weight during the first 6 weeks. And this is potentially an underestimation. Checking weight weekly for 6 to 8 weeks will help spot this early. So if the young person is reporting weight gain to you, but they're not being seen in their clinic every week, this is something that you could encourage. Check your weight every week, and then we at least have kind of a number that we can compare. Giving advice on trying to eat a healthy and varied diet, including lots of vegetables and protein like meat or, chicken or white fish or beans, avoiding sugary and processed foods or fizzy drinks, or eating late at night, which can often happen because of kind of craving for sugar. And then moderate exercise like strength or resistance training for 30 minutes at least 5 times a week can be helpful. The duration of treatment in psychosis, so the antipsychotic treatment should be continued for kind of 1 to 2 years after remission of symptoms, or 1 to 3 years. And the data is kind of different. And there is quite a lot of physical health monitoring that's associated with the antipsychotics. So as I mentioned, children and adolescents are particularly vulnerable to side effects, especially of antipsychotic medicines. And so it is important that their physical health monitoring is carried out. And again, for a child or an adolescent, kind of capturing the side effects and capturing the experience is really important. Bipolar disorder then usually starts between kind of ages 15 to 25. It is extremely rare in young children. Prevalence is kind of maybe 2.9%. It's higher for females than it is for males. The medicines, depending on whether it's kind of mania or a depressive episode, can vary. So aripiprazole, it's licensed in Ireland certainly from age 13 for mania, moderate to severe manic episodes. And then for depression, NICE guidelines recommend fluoxetine and olanzapine for moderate to severe bipolar depression. If that's ineffective, consider quetiapine or consider lamotrigine. Valproate is not recommended in males or females, actually. There's some of the side effects of quetiapine. You can see like quetiapine maybe would be more similar to olanzapine. than some of the other medicines. So it's kind of, maybe higher risk for weight gain. The duration of treatment then in bipolar disorder. So kind of the NICE recommends that the antipsychotics shouldn't be routinely continued for longer than 12 weeks. But again, if someone has bipolar disorder, which can be it's a chronic mental health condition, they may opt to take medicine on an ongoing basis. ADHD. So ADHD is one of the most common childhood neurobehavioral conditions. So ADHD, to clarify, isn't a mental health condition or mental health problem. It's a neurobehavioral condition. So approximately 8 to 10% of children aged 4 to 17 have ADHD. This data was kind of, I'm pretty sure, American. So it's, the criteria are slightly different depending on which diagnostic standards you use. It is thought to be under-recognized in girls and women, and I know I'm certainly seeing this a lot more. That girls or women that I know, or friends or family that are kind of now saying, oh, actually, maybe I have ADHD, and ultimately it is the case. The medicines then in ADHD. So first line is methylphenidate. So for children aged over 5 and young people with ADHD. As I mentioned, medicines aren't necessarily first line in the management or the support that a person with ADHD is offered, but from a medication perspective, methylphenidate is the first medicine that someone would be offered. If the symptoms are still causing a persistent, significant impairment, and that the medicine has been trialed for 6 weeks and is deemed ineffective, or the person can't tolerate it, lisdexamfetamine is the kind of second line. And once, like I said, methylphenidate has been tried at an adequate dose. If it's a case that maybe a stimulant medicine is inappropriate for a person, or can't be tolerated, or is ineffective, you might move on to atomoxetine or guanfacine. So again, if they can't tolerate a symptom or a stimulant, or the symptoms haven't responded to a separate 6-week trial of both methylphenidate and lisdexamfetamine. The side effects then. So kind of the main one really is loss of appetite or failure to thrive, which is important for a child who's obviously growing. Lisdexamfetamine is similar side effect profile, atomoxetine, and then guanfacine. So some support, for someone, a parent who comes in with their young child who's taking methylphenidate and they're, not experiencing their kind of weight and height growth on the standard trajectory. It is it's happening to 1 in 5 young people and children. And checking weight and height regularly is really important. Advice that you could give is for the young person or the child to eat a really big breakfast with lots of protein. So like, pancakes with loads of eggs and maybe some almond flour and nut butter. Setting reminders to eat and to choose foods that have more calories as well. And also planning meals and snacks for the evening. So it's a very short acting medicine. It's usually taken in the morning and released again at lunchtime. So it's that middle of the day period where the child or the adolescent will lose their appetite. But then once the medicine is cleared from their system in the evening, they're starving. So it's great, it's important to have, plan the meal, have it ready to go. So once their appetite returns, they're able to eat it. And I think for children and young people who do experience, where they drop a centile in their growth chart, taking a medicine holiday is sometimes indicated. So they might just take the medicine Monday to Friday when they're in school and not take it at the weekend. So you might see this in prescriptions that, a person is only taking 5 days of the medicine and they don't need it at the weekends. The duration of treatment then for ADHD, an annual review of the medicine. As I mentioned, the drug holidays might be indicated, and also a trial of periods of stopping the medicine or reducing the dose, and trying to establish is it still required. Here's some of the physical health monitoring. So obviously weight and height, blood pressure and pulse, and ECG is only indicated if there is maybe a cardiovascular history, and it's usually in a first degree relative, and then side effects should be assessed regularly. Now, lastly, and we're tight for time, is eating disorders. So, there are obviously different eating disorders. We've anorexia nervosa, bulimia nervosa, and binge eating disorder. There's also avoidant restrictive food intake disorder. which is fairly new, and eating disorders not otherwise specified. Eating disorders are actually the most life-threatening of all mental health conditions. They have a really high mortality rate, and it's caused by suicide as well as the physical health consequences. The prevalence in children and adolescents is kind of, 11 to 19-year-olds. It's obviously 1.2% in boys. It's more common in girls, so 5.7%. And there is an increasing incidence over recent decades. There aren't any medicines that are licensed for anorexia nervosa, just to clarify that. We're seeing certainly olanzapine is being used. There is growing evidence for the possible benefit from olanzapine. It's kind of used, I guess the evidence is around supporting, anxiety and the kind of concerns regarding eating. Aripiprazole has less evidence, but it may be helpful with the kind of overvalued ideas and food rituals in anorexia. Fluoxetine is licensed for adults for bulimia nervosa and at a dose of kind of higher, so 60 milligrams a day. And given fluoxetine is obviously licensed in children from age 8 for depression, it might be an option for bulimia. Topiramate is shown to be effective and well tolerated. Obviously, it's licensed in children for epilepsy. And then for binge eating disorder, there is some evidence for lisdexamfetamine. And I know, there are certain countries like Canada and Brazil, the US, I think, Puerto Rico, Mexico, that have licensed lisdexamfetamine for binge eating disorder. So it's, the evidence is there, and the SSRIs, so there's good indications of efficacy in binge eating disorder. The physical health monitoring for eating disorders, it depends on the medicine. Obviously, there's cardiac risks secondary to malnutrition and electrolyte abnormalities, specifically, for people with anorexia. And so, an ECG is likely indicated. Hypokalemia can also, prolong the QTc interval, so they might also recommend having a U&E. The duration of treatment with an eating disorder, it's unclear, the duration of treatment for an antipsychotic. We kind of maybe see it for 6 months. Often, a young person might be started on the medicine in hospital and then we don't see them again. So we don't really know the length of time. The treatment duration for fluoxetine for bulimia is kind of 2 years is the recommendation. And again, it's unclear the duration of treatment with a stimulant or an SSRI for binge eating disorder. We're nearly there now, thankfully. Here's some just information resources for you guys. So for kind of medicines information, whether, for yourselves to kind of refresh your memories, we have the Youth Med Info resource. I'll show you on the next slide. Medicine for Children is also really good. Like it's an information leaflet that parents would be reading for their child. And it's helpful. It's a UK-based organization, but it's, it's really user-friendly and it's a nice one. The BAP guidelines are really helpful as well. So this is the British Association for Psychopharmacology, and they actually have a publication on common, this is where some of, it's one of the references, but common questions that they come into contact with in CAM services. So it's not necessarily that there's a huge evidence base for a particular query, but, this was their kind of consensus recommendation as a group. So that's the Youth Med Info resource. So it's just www.youthmedinfo, youthmed.info. And we have at the moment 26 videos. So they're for children taking medicines for ADHD or adolescents taking mental health medicines or ADHD medicines. We're adding more, and we have 4 more medicines and some side effects videos as well. So I will absolutely share the slides with the team, but has anyone got any questions?
Thanks a million, Caroline. That was fantastic. And I think as a community pharmacist, I particularly loved your slides around supporting with side effects and those slides, and then the resources. And I think anyone who hasn't looked at Youth Med, I'd really recommend them to look at it. It's really well done and really well explained for kids and adolescents. There's one question here from Noreen about trazodone in eating disorders. Is it used?
I've never seen it. I'd see it more. It's kind of one of those medicines you'd see more for like an older adult, maybe for mood, maybe mood related symptoms with dementia or kind of even depression. Yeah, I haven't ever seen it.
Yeah.
Again, with eating disorders, I think it's very grey. Like there isn't a huge amount of evidence. Like olanzapine, and it's funny, olanzapine is a funny one because when you talk to someone about taking olanzapine, they assume, oh, I'm taking this because the side effect is weight gain, but actually that's not. And generally, which I think is really interesting, now this is anecdotal from people taking it, for someone with an eating disorder in particular, maybe anorexia, they're used to feeling hungry. So when they take a medicine that makes them feel more hungry, it doesn't make them eat necessarily. So I think that's interesting. And that's kind of reassuring, because when you say to someone, oh, you're prescribed olanzapine and one of the main side effects is weight gain, that's really, really overwhelming. So actually kind of saying, well, actually, the main side effect, whilst weight gain occurs, it is through increased appetite and some other kind of biological changes. But actually, because you have this experience of anorexia, you are better able to overcome this, kind of intense feeling to eat. You're used to feeling hungry. And you're better able then to not act on it, if that makes sense. So, and that actually does provide reassurance to people who are taking it.
Thank you. Actually, Noreen has clarified she was not talking about eating, but in general. But I think your answer is probably
okay.
The same, yeah. And the questions are coming in fast now. Mary Claire has a question around weight gain as a side effect, and is there a risk that it could precipitate an eating disorder, and does that need to be checked or monitored also?
So yeah, I mean, with olanzapine, so we would see it. It's very low doses, so it's kind of the RCTs carried out were like for a young person, it was kind of 1.25 milligrams a day. We would see maybe 2.5. The most I've seen is maybe 7.5 milligrams. So it is very low. And typically, once the person has recovered, once they've kind of gone to their target weight, and at that point, generally they're kind of receiving the other psychological interventions and supports. Because we only see inpatients, I don't know how long it's being continued for in the community. But it doesn't seem to cause weight gain in the same way as it would an adult with, a severe mental illness like psychosis, who also has other kind of confounding factors, and might be more susceptible to that side effect.
Yeah. And then Leona has, which SSRI is least likely to affect sleep? I see sertraline and melatonin prescribed together. Is this because of sleep side effects?
It's possibly because if it's for anxiety or depression, one of the symptoms is possibly that they're experiencing insomnia. So it's maybe that they're trying to improve sleep, and also then manage the symptoms of the anxiety or the depression. Melatonin, it's interesting. I went to a day it was the Royal College of Psychiatrists had their Child and Adolescent Mental Health Day, and it's really interesting when you look at melatonin. So depending on the indication, so if someone is having trouble falling asleep, actually the immediate release melatonin at a lower dose earlier in the day, so like 4 p.m. is better. And then if someone is waking frequently during the night, it's the prolonged release, so the one we know, the Circadin, is preferred, 1 to 2 hours before bed, because the prolonged release obviously releases it gradually throughout the night. But sleep latency, which is the ability to fall asleep, is better managed with a really, really low dose, like sometimes 0.5 milligrams of melatonin at like 4 p.m. So, and I think that's information that isn't really well known or well established.
No.
So, yeah.
I wouldn't have heard that before. And Amanda actually has another question about melatonin. Like, is there much evidence for it in children and youth, as it is frequently prescribed?
So yeah, I mean, melatonin, it's in Ireland, obviously it's a licensed medicine, but outside of Ireland, you buy, it's technically a supplement. So I'm not familiar, like it's certainly used, and in autism and ADHD, melatonin is a medicine that is used a lot to support like that, the kind of ability to fall asleep, or to stay asleep during the night. So there is obviously evidence to support it. And it's used a lot, and given it is, we produce melatonin, it is a supplement as opposed to like an active medicine.
And when we're talking about there's so many questions, Caroline, hopefully we'll get to them all. But we were talking earlier about you just mentioned evidence-based there, and then I suppose the NICE guidelines and then unlicensed medicines. What advice, I suppose, would you give to community pharmacists around managing all that, or the best way to know or
I
keep up
think,
to date with prescribing?
yeah, I think it's really helpful to know what's licensed outside of Ireland, because then you know it's safe and effective in that age category. So like I find America, because the FDA have actually kind of implemented a new regulation around licensing a medicine that it's not ethical technically to carry out, studies in young people, but they do need to ensure that the medicines are their safety is established in young people and in children. And so a lot of medicines are licensed in the US. And even like I would always look at the US, Australia, the UK, and try and determine are the medicines licensed there, because then there's been studies, they've done clinical trials, they've established the safety and the efficacy of the medicines in those countries. So that's kind of one to look at. I mean, as I mentioned pre-recording and before being on, that actually, like a lot of the guidelines that the prescribing guidelines are old. Like the NICE guidelines are old, over 10 years. Like there was a guideline I was reading, the American Association of Child and Adolescent Psychiatry guideline on bipolar disorder, which is from 2007, but it was recommending valproate, and I was like, no, that's
Oh, yeah.
that's not really a recommendation now. It's nearly 20 years ago. So I think looking at the licensing outside of Ireland would be really helpful, because then the safety and efficacy of the medicine has been established.
Yeah, and I haven't looked up BAP before, but I definitely will after this, and looking at those common questions and things. There's another question from Jay here, around someone who's not happy with what their doctor's prescribing. I'm wondering, is there a helpline or contact details in Ireland that would be useful? It's around an autistic child that's only on melatonin.
Okay, yeah,
I don't know if that's relevant or.
Yeah, again, it's kind of like I'm actually on the National Clinical Advisory Group, which is essentially kind of a group of all the disciplines that maybe are involved in child and youth mental health. It was set up by the Office of Child and Youth Mental Health, and there is a kind of an overhaul of CAMS and a review of the CAMS services, and certainly there is a kind of a single point of access that will be established, and if someone isn't happy, like it's difficult if someone, if that's the team in their catchment area, it is hard to know. I mean, maybe seeking advice from their GP, or asking within the service if they could maybe see a different team. But yeah, it is. I mean, that's kind of more of a service question as opposed to medicines, unfortunately.
Yeah. Elaine has, in practice, you see many patients affected by prolonged QTC to an extent where citalopram, escitalopram needs to be discontinued, or is it only a problem with patients with congenital long QTC?
I have never seen escitalopram or citalopram prolong someone's QTC interval. So essentially, I think it was 2011, the manufacturers, based on no new data, had just reviewed existing data and determined that there was an increased risk. So they contraindicated it with other medicines known to prolong QTC interval, and in people who have like that congenital long QTC. And so I've never seen it, but like that, it would be prudent to recommend an ECG for someone who is prescribed escitalopram or citalopram with another medicine that prolongs QTC interval. So typically, like an antipsychotic really is the main one for children and young people.
Yeah. Leona has another question. Would citalopram or escitalopram have less effect on sleep than sertraline?
Not necessarily. They kind of have a 24-ish hour half-life. Sometimes, when young people do report sleep difficulties with an SSRI, I would sometimes say, would you take it at 7 a.m. as opposed to 9? So take it literally first thing in the morning. If they've been taking it for a while, they should be kind of over the nausea and vomiting, but taking it as early in the day as possible, so that like that by the time it's time to go to bed, there is slightly less in their system. And also obviously recommending good sleep hygiene, but that's probably a silly thing to say, but it's always worth saying kind of dark lights and reading a book, or not being on your phone or screens.
Yeah, absolutely. Why lisdexamfetamine prescribed along with aripiprazole? I don't know. Is that
again, as I said, sometimes you're targeting symptoms and not a diagnosis. So maybe someone might have, again, this dexamphetamine is obviously licensed and used for ADHD, but also could be for binge eating disorder. So it depends on the indication. I wouldn't really be sure, but like that, it might be a case that they have ADHD with comorbid another difficulty or another condition.
Yeah. Hard to know that the case. Yeah. Owen has thinking specifically of depressive disorders in adults. Most studies of antidepressants have a very short follow-up, so no more than a few months. Are there studies following child prescribed psychiatric medicines over the longer term, like following into adulthood, and whether long-term use of meds improves outcomes in adulthood?
It's hard to know. Again, like the studies are in children and adolescents are also shorter term, and it's always a case of balancing. Like everybody is different, and you really can't say, make a generalized statement that taking this medicine longer term will mean you'll have a better outcome. I think it's really important to support the individual, and if it's their choice to continue it, absolutely, support them in that regard. But if it's their choice to stop it, it is their choice. So there isn't, it's the same as adults. There isn't, a huge amount of long-term studies on the impact of taking a medicine during childhood or adolescence and then into adulthood, or what it means for adulthood. But when you look at the data, like half of mental health conditions present by age 14 and 75% by age 24. And so it is that, if someone is experiencing difficulties, that it's going to carry them into adulthood.
I think we've got everyone now.
There's one, is 200 milligrams of sertraline excessive for teenagers. So actually, interestingly, we don't do it in Ireland. We should, and I think it's definitely improving. But pharmacogenetic testing can often determine the dose of a medicine. And I actually had a call with this amazing pharmacist from New Zealand, and she has been involved in genetic testing for a long time. And she was telling me these stories like that. I think a 12-year-old prescribed 200 milligrams of sertraline, and it was because they were fast metabolizers. And so, and then she had another kind of the opposite, where there was a young person who was prescribed 10 milligrams of fluoxetine a week. So it would just take 10 milligrams over a week. And again, it was because they were a slow metabolizer. So I think we'll start to see, hopefully, as genetic testing becomes more kind of mainstream, that we will see this kind of thing, that it will be dosed as per the individual, as opposed to being dosed to, alongside the kind of manufacturer's recommendations.
It's so interesting, and especially when you see the changes in oncology, to think where like pharmacogenetic testing could be for everything, and in terms of side effects, and as so much of your presentation was around supporting side effects, but imagining that in the future. Very interesting.
And also that it carries, I think it would be amazing for a child or a young person, because they have that data for the rest of their life. And when they're older, and if they're prescribed a statin, or if they're prescribed anything else, they can say, well, here's my pharmacogenetic data. Now that can guide the dose or the choice or whatever. So I think it'd be brilliant.
Yeah. Amazing. Caroline, thanks so much. That was phenomenally interesting and phenomenally useful. I suppose as a community pharmacist, you pointed us in the really good direction in terms of resources and guidelines and supporting patients with side effects. So thank you very, very much. It was excellent. Just a reminder to everyone we really appreciate your feedback, and the link to the survey is in the chat box, and Grace has stuck it in there again. So we'd really appreciate your feedback, and the IOP always respond to what people say. To remember to open up your e-portfolio and do a CPD cycle after this, if you're still feeling full of energy before the sun goes down. And that our next webinar is on Wednesday, the 28th of May at 8 p.m. And it's with TENI, the Transgender Equality Network of Ireland, on the provision of care to transgender patients. So thank you very much. And thanks a million, Caroline. That was really super.
No problem. Thanks a million.
Thanks, everyone. Good night.